The next speaker is Khalil Ghanem, and I suspect that everybody in this audience has heard Khalil. Khalil is really one of the world's experts, along with John Brooks, on sexually transmitted diseases. But we put him before the break for two reasons. First of all, he's a phenomenal teacher, and I think he's retired most of the teaching awards at Johns Hopkins. But also, he talks so fast that if you don't pay attention, you'll miss something. So before the break, you really have to stay awake and pay attention because this is about 3 hours worth of information they'll provide in your 25 minutes. So, Khalil?
Dr. Mazur, thank you. I am delighted to be here. Thanks so much for the invitation. And I hope everyone finds these slides useful. So here we go. Are we ready to do some STIs? I have no relevant financial relationships, and we are going to cover a lot in the next 25 minutes. Some good news this year where we're starting to see some declines, particularly with chlamydia, gonorrhea, and some slowing down of syphilis. So I think we are headed in the right direction, perhaps, but we need to see additional years of data before we can be sure. Syphilis rates are still at an all-time high. And so we're going to start with syphilis, and we're going to start with a really tough question. So here we go. A 31-year-old pregnant woman presents to her obstetrician for her first prenatal visit. Among the laboratory tests that were sent, her syphilis CIA, so her treponemal syphilis test, is reactive, and her RPR is reactive at a titer of 1 to 8. Past medical history, she was diagnosed with primary syphilis 11 months earlier at her primary care doctor's office. Now, the doctor used a point of care test for syphilis to test the patient, and he treated the patient with one dose of 2.4 million units of benzathine penicillin G for primary syphilis. A call to the PCP's office today confirms that the point of care test was used and there was no RPR done at the time of treatment. So we don't know what the RPR was at the time of treatment. Her social history, she reports two opposite sex sexual partners in the prior 12 months with intermittent male condom use. Her physical exam is completely normal. So 11 months ago, treated for primary syphilis, now comes back with a titer of 1 to 8. So what is the most appropriate next step? The titer is low, so no additional treatment is warranted. Remember, she's pregnant. Test the partners, and if negative, do not treat the patient. Treat the patient with a single 2.4 million unit dose of IM benzathine penicillin G. Treat the patient with 3 doses of IM benzathine penicillin G, or treat the patient with 2 weeks of oral doxycycline. So make your best guess. This is a tough one. All right. So what we see is that some people want to do 2.4 million single dose. Some people want to do 3 doses. And a few people want to do, one person wants to test the partner. So the answer here is complicated. The titer is low, so no additional treatment is warranted is the wrong answer. She's pregnant. She's had exposures. You don't know what the original titer was. So all of you got that right. Test the partners, and if negative, do not treat the patient. The problem is access to the partners. She's pregnant, and treatment rapidity is absolutely essential. So you want to treat as soon as you can. And so that B is probably not the right answer unless you really had immediate access to the partners, which often you don't. Treat the patient with a single dose of 2.4 million units. Remember, her last treatment was less than a year ago. If she got reinfected, she probably has early syphilis. And so you can go ahead and treat the patient with a single dose, and that would be my answer. Now, some people would say, oh my gosh, and what if she had been treated and she had had syphilis before that and she didn't respond, and now it's been over a year from the time that she was initially diagnosed with syphilis? I feel so much more comfortable giving 3 doses. Fine, give 3 doses. So I think C and D are reasonable options. I would pick C, but I understand why people picked D. Treat the patient with 2 weeks of oral doxycycline in the setting of pregnancy. Although the data suggests that it's safe, you probably don't want to do it, particularly if you have access to penicillin. So the answer that I would go with is C, but I accept D completely. I think it's a very reasonable answer. So just as a reminder that in about 40% of patients who get syphilis, remember that that organism spreads to the central nervous system within a few hours to days after exposure, even before primary syphilis. So always, 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 whenever you see a patient with syphilis, ask about neurological, ocular, and otic manifestations. The otic manifestations are hearing loss, tinnitus or ringing in the ears, or vertigo. It's really important not to miss these central nervous system manifestations or complications of syphilis. Again, as I said earlier, the rates of syphilis have started to decline, particularly among men. Among women, we're seeing a slowdown, but not a decline, a real decline yet in between 23 and 24. Unfortunately, congenital syphilis, there is a slowdown, but it's still increasing, and the rates really are at a very high level. And so while it appears promising, the rates are still exceedingly high, and we have to be very vigilant at screening our pregnant patients. The therapy for syphilis has not changed. Always try to use penicillin whenever you can. With early syphilis, all you need is a single dose of 2.4 million units of benzathine penicillin G. Latent syphilis, you can do 3 doses, 1 dose each week for 3 consecutive weeks. Obviously, you can use doxycycline, 2 weeks for early, 28 days for latent in non-pregnant adults. And for neurosyphilis, ocular syphilis, and otic syphilis, it's 10 days of IV penicillin. You certainly could use IV ceftriaxone. The data on ceftriaxone are not huge. We don't have a huge amount, but they are reasonable. And I want to cover now the point of care and at-home testing. There are now 2 point of care tests that are available, and there is an at-home test that is available. You can see it on the right here for $38. Patients can do the whole test at home. All of these tests, they will detect treponema-specific antibodies. So if somebody had syphilis in the past, there is no point in using these tests because they should come back reactive. So if somebody didn't have syphilis in the past, you can use this test. And if it comes back positive, then the possibilities are it's a false positive or the patient is infected with syphilis. Those are the 2 main options. And remember that if somebody was infected in the past and was treated, they're still going to be positive. So with our patient, obviously, her treponema antibody today, when she comes back, is going to be positive because she was treated 11 months ago for syphilis. So it makes no sense to ever do another point of care or at-home test on her ever again once she's been treated for syphilis. So a negative test result means they don't have syphilis, or they may have very early syphilis and the antibodies haven't had time to become reactive. So we just covered this, and it makes it very complicated to manage patients if you don't have a baseline RPR titer at the time of treatment. You just saw that with our patients. So my recommendation is, if you see a patient who's never had syphilis in the past, you can certainly use these tests. But remember, if there's any way you can get an RPR titer at the same time as the treatment, that would be incredibly useful. If there's absolutely no way that you can get an RPR titer at the time of treatment and the test comes back reactive, then you should just go ahead and treat the patient, bite the bullet, and then we'll have to deal with the consequences down the line. So always, if you can get an RPR titer at the time of treatment, it's worth it because it makes life so much easier. Now, prevention of syphilis, you all know DoxyPEP. You've all seen the data on DoxyPEP. DoxyPEP, 200 milligrams of doxycycline within 72 hours of a sexual exposure reduces the rates of syphilis and chlamydia consistently by in 70% to 80%. And gonorrhea, it's a little more touch and go, and we'll cover a little bit more of that in a second. But for syphilis, incredibly effective, and for chlamydia, incredibly effective. The DoxyPEP guidelines are at this are at, in the MMWR. I encourage all of you to consider reviewing these. Remember, it's recommended 200 milligrams within 72 hours of an exposure in MSM or transgender women who have had curable STI in the prior 12 months. Again, very effective, but keep in mind that whenever you're using antibiotics on people, there is a price to pay. This is a brand new study that is in press, and these data were from the DoxyVax study that was conducted. And what they did was they looked at gonorrhea among individuals who were infected with gonorrhea and who got DoxyPEP versus controls who got gonorrhea. And they compared the gonorrhea strains in those who got DoxyPEP and those who didn't. And they found, of course, an increased rate of high-level tetracycline resistance, which is completely anticipated. They also found decreased susceptibility to cefixime, the oral antibiotic that we use to treat gonorrhea. It was more frequently found in DoxyPEP. And this has been an issue, and this was raised as a potential concern early on. And the numbers were very small, so it's tough to know exactly whether DoxyPEP was responsible or not. But it is concerning. The MICs to ceftriaxone, fluoroquinolones, and azithromycin were similarly distributed. So with DoxyPEP, we have to keep in mind that whenever we use an antibiotic to prevent an infection, there is a price to be paid. And so it does not come at zero cost. Now, the question is, how steep is that price? And I think the answer is still unclear, but clearly there is a price to be paid. Now, also keep in mind that if you're giving somebody doxycycline intermittently and they get infected with syphilis, the manifestations of syphilis are going to be attenuated. And this is a very nice study by Chase Cannon from Seattle, where they looked at individuals on DoxyPEP who got syphilis versus those who were not on DoxyPEP. And a higher proportion of symptoms of primary syphilis were seen among non-DoxyPEP users. So DoxyPEP attenuated the symptoms. Again, not surprising. And it also attenuated the serological increase seen with syphilis. And what they found was that the median RPR titer in DoxyPEP users was 1 to 8 versus non-DoxyPEP users who got infected with syphilis, where the median titer was 1 to 32. So the take-home message here is that if you have somebody on DoxyPEP, they're taking intermittent doxycycline, you should have a high level of suspicion if you think that they got reinfected, even in the absence of overt clinical manifestations and a fourfold increase in titer or more. And so it makes it harder to manage reinfections with syphilis. So DoxyPEP, excellent at preventing syphilis and chlamydia, but it comes at a price, both in terms of resistance and in terms of our ability to diagnose and manage syphilis. So keep those things in mind when you're talking to your patients about DoxyPEP. Now let's move on to gonorrhea, and the rates of gonorrhea are declining slowly in both men and women. And this is our second question. A 39-year-old man presents complaining of a urethral discharge. He reports 2 same-sex partners in the prior 3 months with intermittent condom use. A nucleic acid amplification test performed on first catch urine and a throat swab are both positive for gonorrhea. Rectal testing was negative. The patient has a history of an urticarial reaction to penicillin 11 years earlier, and he has not taken any beta-lactam antibiotics since then. So the question here is, what is the most appropriate course of action? Treat his gonorrhea with 500 milligrams of intramuscular ceftriaxone. Treat him with 800 milligrams of oral cefixime. Treat him with 2 grams of oral azithromycin. Treat him with 500 milligrams of oral ciprofloxacin, or treat his gonorrhea with 5 milligrams per kilogram of intramuscular gentamicin and 2 grams of oral azithromycin. Please go ahead and vote. What will you do with this patient who had urticaria 11 years ago? Okay, here we go. All right. Beautiful. So most of you would treat him with 500 milligrams of ceftriaxone, and you got that right. Take out that ceftriaxone and give him the ceftriaxone. And we're going to talk about that in just a second. Remember, for pharyngeal gonorrhea, the only recommended agent is ceftriaxone. And also remember that whenever there's pharyngeal gonorrhea that you treat with ceftriaxone, you need to do a test of cure 2 weeks later because ceftriaxone is also not perfect. All the other drugs, cefixime, gentamicin, azithromycin, they have relatively limited activity at the pharynx. And so if you have somebody who truly has an allergy to ceftriaxone and you absolutely cannot use ceftriaxone and they have pharyngeal infection, I would use E, the regimen in E, but of course you would do a test of cure. And at the same time that you're using the regimen in E, what I've done is I've sent a culture and gotten susceptibility testing. So if it fails, if the regimen in E fails, at least I have susceptibility testing that will help me, that will help guide me on the next iteration. Because if it's sensitive to the fluoroquinolones, I would use the fluoroquinolones if I were stuck. So in this patient that we are just covered who had urticaria, remember the first thing to keep in mind, and we just talked about this right now, which is the treatment, which is ceftriaxone 500 milligrams or cefixime, and that's 800 milligrams of cefixime. If you can't use either and they don't have pharyngeal, you can use intramuscular gentamicin plus 2 grams of oral azithromycin. The pharynx, always ceftriaxone. And the first thing you should do if there's a reported penicillin allergy is sit down and talk to the patient. In 99% of the cases of a reported penicillin allergy, you'll be able to use ceftriaxone. So what do you do if a patient reports an allergy to penicillin? Don't abandon ceftriaxone just yet. Get more information. Keep in mind that even if somebody had an IgE-mediated serious allergy to penicillin, 80% of patients with IgE-mediated penicillin allergies have lost the sensitivity after 10 years. But also keep in mind that in patients with a non-anaphylactic penicillin allergy, they can receive any cephalosporin without skin testing or a test dose. These are the new recommendations from the Academy of Asthma and Allergy. For example, patients with a history of urticaria to penicillin can receive any cephalosporin without testing. And so our patient had an allergy, an urticarial allergy to penicillin, but we're giving him ceftriaxone. We gave him ceftriaxone, and that's the right antibiotic to give. Well done to all of those who came up with that. Now, just keep in mind that for now in the United States, we're okay. We're not dealing with extended cephalosporin resistance. We have been blessed for the last many years, but it is a coming plague. These are data for extended spectrum cephalosporin resistance from the World Health Organization, demonstrating high rates of cephalosporin resistance in Cambodia. And they have been documented in other parts of the Far East. So really, it's only a matter of time before we start seeing extended spectrum cephalosporin resistance. And that's going to be a big mess when it does happen. And so if you suspect, I know this is a horrible looking slide, but I wanted to put a summary of what you should do if you suspect cephalosporin treatment failure, because it's a useful slide and it's not easy to find in the 2021 guidelines. So I've summarized it here. What you should do if you suspect that somebody failed ceftriaxone is get cultures, get antimicrobial susceptibility testing, wait for the susceptibility testing to come back, and then based on that, treat them. Also inform the CDC, and you can always send a sample to the CDC for testing. Keep your eyes open, keep your ears open for extended spectrum cephalosporin resistance that may show up on our shores in the not too distant future. Remember when you're getting a culture, if you can get a culture from the throat, from the rectum, same as nucleic acid amplification tests, excellent. But if you're getting a genital culture from the males, you have to use a urethral swab. You cannot get a first catch urine. From females, you need to get an endocervical swab. You cannot get a vaginal swab like you can with a nucleic acid amplification test. So cultures, you've got to get the right specimens. Otherwise, the sensitivity decreases significantly. And keep in mind that culture is about 50% sensitive at the throat and at the rectum as compared to nucleic acid amplification tests. So if you get a negative result on the culture, keep in mind that the sensitivity is not perfect. So remember disseminated gonococcal infection. It is a life-threatening condition. DGI frequently results in petechial or pustular lesions that are acral. So look at the wrists, look at the ankles. Usually it's fewer than 12 lesions. You can also see tenosynovitis and asymmetrical arthralgias, or even oligoarticular septic arthritis. Sometimes you can get complications such as meningitis, endocarditis, and hepatitis. That is rare. And remember that these patients may not have overt genital symptoms. A big risk factor for disseminated gonococcal infection is terminal complement deficiency, either acquired from something like lupus or patients who are on complement inhibitors. There are several of them, including eculizumab. So keep that in mind. And if you suspect it, make sure that you test all of the sites, mucosal sites, throat, rectum, and genitals, with both a culture and a nucleic acid amplification test. The culture is useful to get susceptibility patterns back so that you know what to switch them to, which oral antibiotic to switch them to after when they're ready to go home. You always start with IV ceftriaxone in the treatment of disseminated gonococcal infection. So that's gonorrhea. Right now, we're not dealing with extended cephalosporin resistance, but in the coming years, we are going to be dealing with that. So keep your eyes open. The last one, everybody's favorite, Mycoplasma genitalium. Keep in mind that Mycoplasma genitalium is the biggest pain to treat. Lots of antimicrobial resistance. So the first thing you have to keep in mind with Mycoplasma genitalium is do not test the wrong people. First, if somebody is asymptomatic, never ever test for Mycoplasma genitalium. The only people you should be testing for Mycoplasma genitalium are individuals who have persistent cervicitis or persistent urethritis. Persistent cervicitis, persistent urethritis, you've tested them for gonorrhea and chlamydia and they're negative, and now you're stuck. By all means, now you can test for Mycoplasma genitalium, but do not test individuals who are asymptomatic ever, because then you're going to get into a situation where it's going to be difficult to treat. It's a big mess. So only individuals with persistent urethritis and cervicitis. If the test comes back reactive, then you have to treat them. In most instances, you're not going to have access to molecular antimicrobial resistance to the macrolides. There are non-FDA cleared tests that some laboratories offer where they will tell you whether the organism is sensitive to the macrolides or resistant. But most of us don't have access to it. If you do, and it's sensitive to the macrolides, you can use a week of doxycycline followed by azithromycin 1 gram for one dose, and then 500 milligrams for 3 additional doses on 3 subsequent days. That's the first regimen up here. But most of us don't have access to macrolides. And now in some places, there's 90% resistance to the macrolides, anywhere between 30 to 90% resistance. So what you're stuck doing if you don't know, or if it's resistant, is a week of doxycycline followed by moxifloxacin for a week. Doxy followed by moxie. Now, what's the problem with that? The problem is that 10% to 20% of the organisms are now resistant to moxie. And that's why you want to pull your hair out, because there are no great alternative options. I have tried to summarize what you can do in these situations on this slide. If you have somebody that is resistant or is not responding to the fluoroquinolones, so doxy, Moxie. They didn't respond to that. Then what you need to do, you have an option of using minocycline, 100 milligrams orally twice daily for 2 weeks. Limited data on it, but it suggests some benefit. The other the other study that just came out in the last 2 months, they used minocycline plus metronidazole. And here they use metronidazole 400 milligrams because it's an Australian study and they have metronidazole at 400 milligrams, not 500 milligrams. You can use 500 milligrams here. And they used it for 2 weeks. So they combined mino and metronidazole. But if they preceded that with a week of doxycycline, the results appear to be even more favorable. So here, what they're suggesting is a week of doxy followed by minocycline and metronidazole for 2 weeks. 3 antibiotics to treat this bug. That's why my recommendation to you is do not test anyone that is asymptomatic. Only test those that have persistent cervicitis or persistent urethritis. And if they come back positive, then you can treat them. And you have options to treat them, but they are limited options when doxy-moxy does not work. And so please keep that in mind. Ladies and gentlemen, remember that you can always ask questions from the NNPTC, and I encourage you to use this free service, which is funded by the CDC. Within minutes to hours, you will get a response to your question. Also, remember the National STD curriculum, which has incredible resources. All of those resources are for free, including DoxyPEP resources. We are now ready for the Q&A session, and I spoke very fast, but that's okay. Now you know everything about STIs, and I will stop sharing. Thank you very much.
Khalil, that was great. That was right on time, and that's the slowest I've ever heard you talk. Um, there's a lot of questions about DoxyPEP, but let me ask you a couple of my favorites. First of all, you indicated there are indications for when to give DoxyPEP if you had STIs in the past year. But in fact, for anybody who's had unprotected sexual contact with a suspicious partner in the last 72 hours, would you ever withhold DoxyPEP?
So the data that we have on DoxyPEP are in MSM and transgender women, right? And so in those situations, I would not withhold DoxyPEP. To be honest, I wouldn't withhold DoxyPEP if there was a reasonable exposure. Now, keep in mind, in cisgender women, there was one study that was done mainly in Africa, based in Africa, that did not show benefit, but adherence was very low. A second, smaller study showed some benefit in women. It showed benefit in women, but it was a small study. 2 additional randomized trials are being conducted in women. And there was one study that was done from our colleagues at the CDC looking at doxy levels in the vaginal fluid as well as rectal fluid in women. And they found very high levels. So there is biological plausibility that DoxyPEP should work just fine in cisgender women, but there are no great data there. So I think if you wanted to use it in a cisgender woman, I think that's the time for a good, sitting down and really talking about the limitations of the data and coming up with a potential approach with the patient and when the patient is fully informed about our limited data in that
All right,
population.
just to pin you down. So a heterosexual man comes in within 72 hours of a sexual exposure with somebody they had reason to suspect. What does Khalil Ghanem say? They say, thanks for all the data, but what should I do?
So what I would do is sit down with the patient and say, this is what we know about DoxyPEP, and we know that it's effective, but we also have most of our data among people who've had an STI in the prior 12 months, but it has the potential to decrease the risk of chlamydia and syphilis. What do you think? And if he says, you know what, I think that sounds smashing, then I would say, okay, we're going to use it. That's
All
what
right.
Khalil Ghanem would do.
Let me ask you one other than Mike, I'm
Yeah.
sure, is looking at some of the online questions. Let me, you talked about allergies, and one of the things that is often complicated, and maybe it's not fair to ask a non-allergist, is somebody says they had mild urticaria in the past. It wasn't life-threatening. Do you just go ahead with the ceftriaxone? Do you give them amoxicillin challenge, or what do you do?
Take out the recommendations from the allergy and immunology gurus is that if it's urticaria, take out the ceftriaxone and give them the ceftriaxone. There is
There
no
shouldn't be cross
reason to do
reactivity. Yeah.
testing.
Yeah.
Yeah.
Mike, I'm sure you have a couple from that online list or the Q&A.
Yeah, we do. Um, so uh, when we're talking about the rapid test at home for syphilis,
Mhm.
and you mentioned its limitation. It's really only going to tell you if they've ever had it or before or never had it, sort of. Do you find that test helpful?
So I'm going to be really careful here. I think in a setting where you have no access to any testing, right? In a setting where there's no access to testing, these tests are incredibly useful, right? Because if you ask somebody, have you ever had syphilis before? And they say no, you can test them and you can treat them. And so in such settings, and I'm here talking particularly in the US, overseas where they don't have access routinely to tests, they've transformed the ability to diagnose particularly pregnant women syphilis. And so they have had a
Yeah,
huge impact overseas. In the
yeah,
United States, they're going to have a more limited impact. Now,
mhm,
if you decide to use these tests, I think they should be used if they're going to help you make a decision about treatment. If you're able to get a baseline RPR at the time that you're treating the patient, I would strongly encourage you to do that because it will make life a lot easier down the line. You saw from
yeah,
that first patient where it
right,
makes it almost impossible to manage the patient. But
yeah,
if you don't have access to a baseline RPR and the patient didn't have a past history of syphilis and you get a positive test, take out that penicillin and treat them.
yep,
It,
got it.
it has utility in certain settings.
Yep. So Jarrett Sell from Westside Family Health in Wilmington, Delaware, is asking about the need for treating, testing and treatment of an asymptomatic partner of those confirmed to be a partner of somebody with M. genitalia.
So the recommendation, it's a great question. Thank you for that. The recommendation for partners, usually for syphilis, chlamydia, gonorrhea, the CDC says, listen, get the partners and treat them. You don't even have to test them. Just go ahead and treat them. And if you test them, even if the test is negative, treat them. For Mycoplasma genitalium, it's different. They say, if you can test the partner and the partner is negative, don't treat them. If you can test the partner and they're positive, treat them with the same regimen that you use to treat the index patient. If you can't test the partner, treat them with the same regimen that you used on the index patient. So the only exception to the rule of don't test somebody who's asymptomatic is testing the partner of an index patient who has Mycoplasma genitalium and was treated for Mycoplasma genitalium. That's the
Could
only
you,
exception. So
Khalil,
I
could you just
appreciate.
for what sexually transmitted disease do you not test the partner?
So it's hard to think about a sexually transmitted infection that you don't test the partner or you don't empirically treat the partner, right? If you look actually for Calamidobacterium, right? So Granuloma inguinale, there are no data on partner therapy, although the recommendation is treat the partner, but nobody knows how much to give, etc., for partner treatment. Because remember, for granuloma inguinale, the treatment is prolonged until the ulcers go away. So although they say treat the partner, but they don't really tell you with what to treat the partner. And so that's the one example. But otherwise, yeah, you got to treat for curable STIs. You want to go after the partner.
Yeah,
But for Mycoplasma genitalium, if you can test the partner and they test negative, don't treat them.
yeah, but no such thing as immaculate infection.
There's no, there's no, that's right.
Yeah, got it. So we have Janice Huber, who's from Lawndale Christian Health Center in Chicago, is asking about people who are intolerant of doxy. Are there any other agents or drugs in the pipeline or studies being done for PrEP or sorry, PEP in those settings?
So the data, I'm not aware of any data looking at alternatives for DoxyPEP. There were very old data looking at penicillin for the prevention of syphilis, and these depot concentrations of penicillin, and they worked. But I'm not aware of any data for modern data that will replace doxycycline. It's kind of hard to think about a regimen that would have such broad activity against syphilis, gonorrhea, chlamydia, etc. So I'm not aware of any. If there are, I just don't know about them.
Let me ask one last question, then we'll give you the break. And I've heard you answer this before. For neurosyphilis, if you don't want to give IV penicillin, what's your option? Or do you have to change your mind?
IV ceftriaxone.
Hmm?
Mm.
There are no options. So there is now a trial that's going to be launched for neuroocular and otic syphilis, where we're going to compare IV penicillin to oral high dose doxycycline, 200 milligrams PO BID for 28 days. It is a
Would you like to be
yes.
randomized?
Yes. If I had neurosyphilis, I would say give me doxycycline. The data are limited for syphilis, but we do have data and it works very well. And we have plenty of data for neuroborreliosis, etc. And I would much rather take oral doxycycline, but I don't recommend you use it on anyone other than yourself if you get, because you could not defend it in court if something bad happens. And so the recommendation is IV penicillin or IV ceftriaxone if the patient is walking out of the hospital through a self-directed discharge. They said, I'm not taking anything, I'm leaving, then I would encourage you to write a prescription for high-dose doxycycline because that could be life-saving for the patient, but I would not offer it to any patient who's not walking out of the hospital because we just don't have data. The study will be done in 4 to 5 years, and then we'll have data.
All right. Well, I've learned something. That wasn't the answer I was expecting. And for the patients who walk out of the hospital, if they're going to take their full doxycycline, that would be a surprise. But
Yeah.
in any event, thank you, and we'll see everybody at 3:10.